A very good evening to everyone. Thanks for joining us this afternoon or evening or maybe morning in some parts of your region. Tonight we will have two speakers to talk about very important topics, reproductive conditions and consequences for menopausal health and management. Before we start the webinar, could we go to the next slide? This webinar was supported by an unrestricted educational grant from Besons Healthcare, and Besons Healthcare had no role in the selection of the topics and selection of speakers and have not been vetted or reviewed the content of the speaker's presentation. So I will go on to introduce our first speaker, Professor Bart Fauser. Professor Fauser is the Emeritus Professor of Reproductive Medicine, UMC Utrecht, Netherlands. He was a former professor of reproductive endocrinology and director of reproductive medicine, Erasmus Medical Center, Netherlands, and Sylvain Zenenberg Professor of Free University, Brussels and Belgium. He was visiting professors to many international universities such as Stanford School of Medicine, California, University of Siena, Italy, University of Southampton in UK, and University of Adelaide in Australia. He chairs the WHO Steering Committee on Infertility Guidelines and is a senior editor in the Reproductive Biomedicine Online. He was also the former editor of Human Reproduction Update, and his major interest is in the pathophysiology of human ovarian function. We look forward to hearing from Professor Fauser on polycystic ovarian syndrome and how do we deal with it in the menopausal year. Professor Fauser, please.
Good day, dear colleagues, Mr. Chairman, Professor Kiesel. Polycystic ovary syndrome is certainly a condition that has been the focus of my research attention for quite a while. And considering the focus of the society today, I will predominantly focus on the potential long-term health implications of this condition. So my disclosures, the chair has mentioned quite a few of them. I don't really think that any of my activities at present or in the last 5 years is really relevant for today's topic. Polycystic ovary syndrome is a much debated, extremely heterogeneous condition. In my earlier days, the focus has been almost exclusively on reproductive dysfunction in terms of bleeding disorders, hyperenergenemia and its implications, but most importantly, infertility. In more recent years, the focus went beyond these two major topics, and now there's much focus on pregnancy complications and suboptimal perinatal outcomes and its future implications for health of offspring, which I will not discuss today. Today, I will predominantly focus on the metabolic conditions and its potential implications for future life. And in that respect, you can see that there is a major shift in attention from early reproductive years, where it's been mainly related to bleeding abnormalities and infertility, to more later reproductive years and older age, and there all new specialties come in and gained interest in this condition, like diabetologist, geriatrist, cardiovascular, cardiologist. So it became really a condition of interest for many different specialties in the overall healthcare system. As gynecologists, we usually start seeing these patients around infertility, which is certainly also what we do. And we have been interested in these conditions for decades. And we started standardized phenotyping, and as you will see later, follow-up studies as well. And when we do the standardized phenotyping in the women diagnosed with polycystic ovary syndrome, according to the Rotterdam criteria, you may not be surprised, then you see that in our hands, in our population, and this involves more than 2,000 women, that about the red part of the circle, you see that about 50% of those women are characterized by ovulatory dysfunction, OD, and by polycystic ovary morphology, PCOM. So not elevated androgen levels in about 50%. That may vary from country to country, and in our circumstances, obesity is on the rise, but not that prevalent as compared to some other countries. And there are maybe ethnic differences in androgen levels, but at least in the Western European, predominantly Caucasian population, it's about 50% with normal androgen levels. This has implications for infertility treatment and possibly pregnancy complications, but it may also have implications for later life health. And why am I saying this? Because when you compare these, the polycystic ovary syndrome with hyperandrogenemia and without, you see body weight, blood pressure, LH concentrations, SHBG levels, insulin, cholesterol, all parameters are significantly different. So again, you see when you talk about sort of the container PCOS, you see that a lot is information is hiding also from the metabolic perspective by making a distinction between the one with and without hyperandrogenemia. So now we know that often this condition is first diagnosed at an early age. Although not part of the diagnostic criteria, we know that there are many associated features like obesity, insulin resistance, hypertension, and some other factors associated with the metabolic syndrome. So there are distinct biochemical abnormalities at a young age. We now know, and I will show you some of the data, that surrogate outcomes are often abnormal, like intima media thickness and flow-mediated dilatation, two important sort of gold standards for later life cardiovascular risk. We know that intermediate outcomes are abnormal at later age, more prevalent abnormalities, especially type 2 diabetes. But I would like to focus today on the potential cardiovascular risk in terms of real life events. What are the data that we have today and how convincing or controversial are these? This is a meta-analysis on IMT. I will not go in any details here. You must be very familiar with this kind of chart. You see that the odds ratio is clearly different when you compare the one, the abnormal and the normal IMTs. So it's clearly abnormal in PCOS, and the same and maybe even more prominently for the flow mediated dilatation. Another meta-analysis published quite some time ago, as you can see, that also FMT is clearly abnormal in women with PCOS. So indeed, cardiovascular risk factors. When you look at the earlier studies regarding long-term health implications of PCOS, and we summarized these early studies a couple of years ago, these were really mainly retrospective studies. So four bigger studies, one from Scandinavia, it's the Dahlgren group. I will show another publication a little later. Pierpoint is the UK, Wild is the US, and Elting is a Dutch study. And you see here this between 35 and 1,000 women, but of course retrospective analysis, so that you can have some questions about the robustness and validity of these trials, but they all show abnormal in intermediate outcomes, as you can see here, but the ones that assess the true cardiovascular disease events, 2 out of those could not show a difference between PCOS and controls. This is a highly publicized study that was published 2008 in JCNM, a respected journal, and it was part of the NIH WISE cohort. 390 women were followed in this WISE cohort, of which 104 was diagnosed with PCOS. This was the average age and the average age difference with menopause. And this particular analysis showed and came to the conclusion that PCOS, more diabetes, more obesity, more metabolic syndrome, and more coronary artery disease. And when you look at the cumulative cardiovascular event-free survival, you could see a clear and significant difference. So this was really the first study that gave rise to a lot of concern that indeed women with PCOS have an increased later life risk. But it required some digging. About 10 years later, this study was withdrawn. And it's not really clearly stated in the journal why it is withdrawn. Only later on I found out the study was withdrawn and republished in another journal with another author, another first author. And there they stated that based on somebody for a meta-analysis asking for the data, they found out that there was a coding error. And when they corrected for the coding error and reanalyzed the same data, there was no difference. So this paper is still widely cited and widely mentioned as a proof for abnormalities in cardiovascular risk in PCOS, but the data, when analyzed correctly, showed no difference. This is another paper that show a clear difference from Roger Hart from Australia, also published in JCNM, showing, and their conclusion was PCOS is profound implications for future health of women. All the parameters they looked at, mortality, depression, asthma, cerebrovascular accident, all significantly different. And I've been looking at this study carefully, and I discussed it with Roger Hart, because later on you will see that this is not confirmed by many other studies. I think the crux here is the inclusion of patients. And the inclusion was hospital records, 2,500 women with labeled in the hospital with PCOS. So it may be true that for hospitalized PCOS patients, there is a difference, but I'm not sure how representative it is, because we know that it's only a minority of PCOS patients that are hospitalized. So maybe the more severe phenotype. So I told Roger Hart that I think that they should modify the title and say potential implications of hospitalized patients diagnosed with PCOS. This is another chart from the same paper. When you look at diabetes, hypertensive disease, they also showed a significant difference in cervical cancer, which is not confirmed by any of the other studies. This is another study from the US in Rick LaGrosse group, and this involves the women's health across the nation. Also a well-known follow-up study like the first one in the US, 1,000 women, 12 years follow-up, and these women with a history of irregular cycles, high androgen levels, and no signs of metabolic syndrome at baseline. That were the inclusion criteria for these 2,000 women. And again, without going into details, the conclusion of this particular study was no association with worsening of metabolic health after menopause. So again, a population-based cohort study where they defined a subgroup with inclusion criteria as a proxy for PCOS. We don't really know the history of these women and whether they were diagnosed with PCOS at a younger age, but there no difference was seen. This is a paper from our own group, jointly with Rotterdam, with Joop Laver's group, published in JCNM, and this is also a very well-known population-based large cohort study where 2,500 women were identified above 55 years of age. The mean age was 70 years, and the mean duration of follow-up was 11 and a half years. And here, when you look at stroke-free survival and cardiovascular disease-free survival, no association between these PCOS patients, again diagnosed by hyperenergenemia and a history of irregular cycles, and so no difference. And look at the sample size, 100 versus 171 in this total cohort. Then this is the Dahlgren group from Sweden. They were the first actually in 1991 to publish on long-term health implications, but they continued to follow up of these women up to today. So, and 20 years after the initial publication in 1991, they published in JCNM a very meticulously designed cardiovascular follow-up study. So small sample size, but I think a very well-defined characterized patient population. And when you look at this particular study, hospitalized for myocardial infarction, age of myocardial, hospitalized stroke, all cardiovascular disease, breast cancer risk, overall mortality, you see all no significant difference. So what really needs to be done, but that's very impractical, is prospective cohort follow-up studies. So the women diagnosed at an early age, follow up them over time. And we have been doing this and started with our standardized phenotyping in the 90s, when these women, usually in a gynecology practice, these women are diagnosed between 25 and 30 years of age. And we did do already all the pregnancy and children follow-up again, which I will not discuss today, but now about the cardiometabolic follow-up. And of course, you need many decades, because we know cardiovascular events in women basically only takes place after 60 years of age. So when you diagnose them around 30, you need follow-up of at least 30 years, which clearly is very impractical, and there's no funding body that is willing to fund such type of studies. But this is our first paper from this effort, the clinical endocrinology, just a couple of years ago. This is again the collaboration between Rotterdam and Utrecht. So 200 women in the early days diagnosed with PCOS, and we now follow them up 20 to 30 years later, and now on average they're 50 years of age. It may be too young still, but this is what we have so far. And we compared that with 200 age-matched population controls. Not body weight, because the idea is that body weight is part of the pathophysiological mechanisms underlying PCOS. And then we calculated, based on the parameters assessed, that 10-year cardiovascular risk. And when you compare low, intermediate, and high risk, comparing PCOS and controls, as you can clearly see, there is no difference. Very puzzling, and maybe for some unexpected, but we do not see a clear difference in cardiovascular disease in these women on average 50 years of age. And indeed, it may still be too early. And also when you look at all the different parameters, smoking, cholesterol, glucose, BMI, no clear difference. And there is a recent meta-analysis published, a Dutch analysis, long-term cardiometabolic disease in women with PCOS. And this is a forest plot with the composite endpoints of fatal here and non-fatal here cardiovascular disease. And as you can see here, both of them, including one study with a really big sample size, a Finnish study, I believe. And there you see overall, there is no significant difference. So no surprise with all these uncertainties that all different societies come with different recommendations. There is the international society PCOS guideline, led by the Australians, by Helena Teed and Rob Norman. It's close to being updated very soon. So 5 years later, they will come with recommendations for follow-up. But there's also the European Endocrine Society, the American Endocrine Society. So they all give recommendations. What should you do in terms of follow-up? What should you measure? When should you intervene? How often should you assess? And the truth is, we do not really know because we have no solid data. So, as I concluded in a commentary in Fertile Sterile recently, potential later life health implications of polycystic ovary syndrome are underserved and understudied. There are some general health considerations. Endometrial cancer risk is increased. Age of menopause is later. We know that now. It's not being touched upon in this presentation, but this is clear now. Cardiometabolic dysfunction at a young age. We've seen the data. There's abnormal surrogate and intermediate disease outcomes at middle age. I've shown you the data. And about long-term cardiovascular disease, there is still great uncertainty, and we need sound multidisciplinary approaches. First, I think it's valid to say we need robust data. What about the natural cause of disease? I see all sorts of studies with all sorts of interventions already, mainly from medical endocrinologists. But my point would be, let's have a look at the natural cause of disease first. And also, why is this present? We should realize that these women, on top of being obese, which we know is a risk factor, have many other risk factors. How is it possible that women that fulfill all these risk factor criteria do not clearly show an increased prevalence of cardiovascular disease later in life? Are we not seeing some issues? Are there other points that are relevant that we don't know? Are there protective factors? So there is many questions that we need to answer. And for sure, gynecologist approaches is not going to be enough. So we need the expertise of many other areas in medicine. I hope you agree with my statement, and I would be happy to entertain questions later on. Thank you so much for your attention.
Thank you very much, Professor Fauser, for your very insightful talk. We'll take the questions later and after our second speaker finish the session. Please type your questions in the Q&A section in the meantime. Next, I have the pleasure to introduce Professor Ludwig Kiesel. Professor Kiesel is the chairman and professor of Gynecology and Obstetrics, Department of Gynecology and Obstetrics, University Hospital of Munster, Germany. His special interest includes menopause, gynecological endocrinology, contraception, endometriosis, and mechanism of hormone action in breast cancer. He is the current president of German Society of Gynecological Endocrinology and Reproductive Medicine, and has been the past president of many German societies, such as the German Menopausal Society, German Joint Societies of Reproduction, and various endometriosis society in Germany. He has been active as a member of various German and European guidelines on menopause and endometriosis, and I'm sure we will be learning a lot from Professor Kiesel on endometriosis. Professor Kiesel, please.
Yeah, thanks for that kind introduction, and I'm glad to be here and presenting some of our data, what we know about endometriosis, especially with relation to menopause. So that should, so endometriosis is often regarded actually something which occurs in premenopausal women, and that's obviously true. And this is a very enigmatic disease. So we have a lot of aspects and a lot of many details which you know, but the whole picture is quite unclear, especially with regard to etiology, pathophysiology, and also the way we should treat patients. But I think the major problem is to diagnose endometriosis. That's worldwide a problem. So when I was in the World Endometriosis Society, we could see the same problem all over the world, that there is a huge delay to diagnose this disease. And I think if you talk today about something in menopause, that even more true in menopause, because then the cyclical problems do not occur, and we have great problem to see how we can diagnose the disease and also treat it. So here you can see my conflict of interest, where I don't see much in conflict with today's talk. So on this slide, you can see what I think we should be talking about when we discuss endometriosis after menopause. Of course, we have to understand the disease first, which I told you is quite problematic. But still, we have to see how can we understand this problem. So the first question, I think, and also a kind of a learning objective is endometriosis a clinical problem after menopause? The second is how to treat postmenopausal endometriosis, and when and how should we use like HRT in women previously diagnosed with endometriosis. So these are the three points, and I'd like to make just brief introduction about endometriosis, which you're all aware of, which is obviously related to endometrium-like tissue, which is outside the uterus, mainly located on the peritoneum, or as a deep endometriosis such as rectovaginal septum, etc., or bowel, and also the ovary. But today's understanding is that this disease is not just localized in the pelvis, but long-term disease, and this is a chronic disease, will also affect the whole body. So there's a kind of a systemic effect of endometriosis in many women. Nevertheless, it's a benign condition, although it can grow such as very aggressively in some parts of the body, especially in deep endometriosis. So that can cause a major problem. And this is also important for postmenopausal women. Of course, there is a link to the cycle-dependent pelvic pain in premenopausal women, which is not possible in postmenopausal women due to the lack of a cyclicity. And of course, in premenopausal women, endometriosis may affect fertility. So when we think about the symptoms where we could diagnose the disease, this is generally listed for premenopausal women, which is listed here as pain, mainly during menstruation or even before. It can have a chronic pelvic pain, which is also present in menopausal women. Dyspareunia, which is a complex issue in postmenopausal women due to other causes. Dyschezia can happen, and dysuria both in premenopausal and postmenopausal women, and subfertility and infertility obviously in premenopausal women. So we have a wide range of problems, and there is a whole long list even beyond that for premenopausal women, and have some mainly chronic pelvic pain or even some unknown tumors which are diagnosed in postmenopausal women, which can lead to the diagnosis in postmenopausal women. So when we look at this issue of how we should treat patients, the main understanding today is looking at either the production or estrogen action with regard to endometriotic implants. So implantation and progression of the disease is thought to be linked to estrogen production, either systemically or even locally within these implants. So if we don't have so much estrogens anyhow in the menopausal women, there may be different actions how these tissues may grow. And even in premenopausal women, we know that even if you suppress estrogens, you may not actually fully suppress implantation or progression of this disease. So there's a whole lot of points we have to understand to medically treat patients because they have symptoms are mainly related to pain and also the pathology of chronic pain, both in premenopausal and postmenopausal women. And surgery is often used if these medications are not helpful. So the question is, do these endometriosis problems really occur after menopause? And these are two papers basically summarized here, where you can see that endometriosis, which is diagnosed in these centers, actually it can occur many years after the onset of menopause. I think personally that this is mainly due to the lack of ability to early diagnose endometriosis anyhow. The same occurs in premenopausal women. And you can see that in one publication by Kempers and also in other series, there is quite a range of age when these endometriosis after menopause is diagnosed. So that may surprise you that there's actually occurs in women after menopause, and we usually don't think in patients after menopause to look for endometriosis generally. So the first question, whether this actually occurs, it does occur. And it is, of course, a question, is that something new? Well, has been reported initially in 1950, and there is a low occurrence of endometriosis in postmenopausal women. And it has been discussed whether it is mainly due to some kind of exogenous hormones which are added or something other, whereby these lesions shown here in postmenopausal endometriosis can occur. So we have to understand that actually these implants, which may have been there before even, can actually produce estrogens themselves. So as shown here in this list, the last line, that locally elevated level of estrogen can occur. And this is mainly due to aromatase in these tissues. And aromatase inhibitors, therefore, may be very helpful in women in postmenopause or during postmenopausal time for treating these patients. Now, in some patients, you have some unknown tumors, and this is one of the publications showing that in certain unclear tumors, you can actually diagnose endometriosis only because it is found as an unknown tumor which has been diagnosed. And initially it was found, surgery was performed in this patient, and you can see here the endometriosis invading cecum in a postmenopausal patient, and usually it has to be histologically confirmed, and in this patient, relief of pain occurred after this disease has been removed. So what can we actually do if we find endometriosis in women after menopause? Of course, analgesics in chronic pain is possible, just like in earlier ages, and progestins can be useful, and even IUDs, hormone IUDs can be used. And as I showed before, aromatase inhibitors can be used because often these endometriosis implants after menopause have local estradiol production. And I personally have used aromatase inhibitors in these patients to treat for pain, even after several surgeries. So finally, I'd like to tell you more about what we can do in patients who actually have a history of endometriosis. So patients who have been diagnosed endometriosis much earlier than menopause. So the issue is that, or also the fear that if you use HRT in those women, there may be some reactivation of the residual endometriosis, which may be located there, since it's an endocrine-dependent disease. And also the question then that some implants can occur even from stem cells, etc., which have been shown. So this is one fear. And also the question if HRT may actually promote the risk and the occurrence of malignant transformation of endometriosis tissue, which has been shown in those patients. And many patients who have major surgery have a long-term consequences if they have had their ovaries removed. So this can occur in patients as a problem if they have a kind of a premature or early menopause with risks regarding overall mortality, cardiovascular disease, maybe dementia, of course, osteoporosis, and possibly Parkinson's disease. So there should be actually some thoughts about the HRT management in those patients who would like to have HRT but have been diagnosed endometriosis in earlier life. Now the question is, does this really matter? And very few studies, as you can see, has been performed to look at the recurrence of these endometriosis implants in those patients with or without HRT. And it's really a strongly lack of data to prove either point. And there have been indications that there is endometriosis occurring with HRT, and there is a question whether you can use estrogens alone, estrogen plus progestins, and it looks like, as for example, one study which compared this, that if you add progestins to estradiol in HRT in women with a history of endometriosis, they have less recurrence, but numbers are small and data is very scarce. So a big problem what has been seen when there has been a diagnosis of endometriosis-associated cancer, and there are many studies ongoing and some have been already published to demonstrate if actually endometriosis can promote or if there's just an association with certain type of cancers. And number one of these cancers is ovarian cancer, which is in those studies performed, which I summarize here. There's a big review published by Marina Kwaskov about 2 years ago, showing that there is a twofold increase of ovarian cancer. In certain type of cancers have even a higher increase in patients who have endometriosis. So clear cell cancer of the ovary or endometriosis cancer have high risk of endometriosis-related cancer. There is some increase also of thyroid cancer. Breast cancer is significant because of the large numbers, but it's really very little. And cervical cancer is actually lower. It's even if it's lower, reduced. And funnily enough, endometrial cancer itself, at least in this big study, there is no significant increase, statistically speaking. And when you look at the severe endometriosis disease, you can actually see that these tissues have certain genes which are responsible possibly for the malignant transformation, which are very similar to the genes either downregulated or activated in cancer types. So there is a big endeavor at the moment to look at the endometriosis-associated cancers, and some of the studies are still ongoing. So what can we say about ovarian cancer risk? As I've shown you, this is the largest or more prominent risk found. So the risk of ovarian cancer appears particularly elevated in those studies with a long-standing, more than 10 years, history of ovarian endometriosis, especially in recurrent endometriosis, repeated operations, and de novo endometriosis, endometrioma, so endometriosis of the ovaries, in women aged beyond 45 years old. So this seems to be a specific group. And also large endometrioma, especially sizes such as 9 centimeters and above, or with a rapid growth of these cysts. So it seems and that there are some risk factors to diagnose or at least assume that there may be a higher cancer risk in certain women. So what can we actually say with regard of using HRT in menopause about recurrence and malignant transformation? So endometriosis lesions have actually a potential for malignant transformation, which has been shown quite clearly, and this seems to be more severe in women after menopause. So this is something which is appearing more and more due to the awareness of the disease, and also of the effect of HRT on recurrence and possibly malignant transformation should be considered in these patients. And as I've shown you before, there are certain groups of patients which may be more at risk for malignant transformation, for example. So their HRT use may be less advisable. And interestingly, the use of HRT is associated with endometriotic adenocarcinoma in these patients. Now, what can we say how we should treat women with menopausal symptoms who have had a history of endometriosis? And the European Menopause Society has published some years ago kind of guidelines or recommendations for HRT treatment. So the first part of the statement is that women who have a premature or early menopause, mainly due to surgery of the ovaries, they should be considered for treatment, and they have, of course, severe climacteric symptoms. And even though the data is quite scarce, as I showed you before, it is advised to use continuous combined estrogen progestins even in women after hysterectomy. So the addition of progestins, which we don't do in hysterectomized women, is advisable according to this recommendation. And it is quite clear that alternative pharmacological treatment for climacteric symptoms or skeletal protection should be considered in those women. Often women would like to have herbal preparation, but it's not really recommended as the efficacy is uncertain, and we don't know about the estrogenic compounds on its own. So the suggested approach would be that, first of all, we have to be aware that endometriosis may occur in women with chronic pain and unclear tumors, even after menopause. And we have to be aware that there's a possible risk of malignant transformation, and even though the actual numbers are very small. And patients should be advised in case they have endometriosis-like symptoms, especially if they're using HRT. And certain patients may have benefits or risk according to their risk profile. So this has to be discussed with these patients. And there are a number of other considerations, especially if we look at problems depending on premature ovarian failures after surgery. So we have to think about the treatment of patients if they don't need HRT but have pain. So aromatase inhibitors could be a good way of treating patients. And of course, if there are suspicious lesions, there needs to be histology performed after surgery. So I can advise you to look at the ESHRE guideline, which says many different aspects of endometriosis, which may relate to women after menopause. And I'm just showing you all the people who have been involved in the last guideline to perform different aspects of endometriosis. And this also includes publications as well as a list of recommendations around menopause and after menopause. So I hope you will have some awareness for that disease, which is quite enigmatic even during premenopause, but even more so after menopause. Thanks very much.
Thank you very much, Professor Kiesel. Now we will come to the question and answer time. Let me see. There's quite a number of questions to be answered. Okay, maybe we answer the first one. Is it possible that hyperandrogenism is protective in later life to counteract the possible issues with hyperestrogenism in younger life in PCOS patients? I think Professor Fauser, would you like to take this question?
A good question. And the answer is yes, it's possible, but we don't know a mechanism of action. And yeah, there are no really data to support such a statement, but it's possible.
Thank you very much. There's another question is whether menopausal hormone therapy will modify the risk of cardiovascular risk for menopausal women who had suffered from PCOS.
That too is another good question, a relevant question. I've asked myself that question before. I think the honest answer is we don't have really data. I'm not aware of any clear follow-up studies postmenopausal women with or without PCOS under HRT or not. So my guess would be yes, that it will be beneficial for cardiovascular disease if you start early, like in the general population. But in the absence of data, it all remains speculation.
Yeah, that's true. Looks like we need more studies on that.
We need more studies, and also I saw several questions about intervention. I'm not surprised. Inositol, metformin, etc. It is my personal opinion, and correct me if you disagree. But for me, the main question at this stage is what is the natural cause of disease without intervention? Because we may run the risk of, starting with interventions right away, and then later on, we have no clue whether the intervention was beneficial, yes or no, because we always have to be able to compare it with a group without intervention. And I'm afraid that in many parts of the world, many PCOS women are exposed to long-term medication regimens for years and years, and sometimes multiple medication, multiple intervention. But we have to acknowledge that we don't know what the long-term implications are. So before exposing women to long-term medication interventions, it may be good to first ask the question, what will happen without any medical intervention? It's just too early for secondary prevention.
And that's true.
In my humble opinion.
Yeah, thank you. I mean, definitely, while metformin is seen as a very safe drug, I mean, long-term use has been associated with B12 deficiency as well. So I do agree with Professor Fauser whether, before subjecting someone to long-term use, we really need to have good data to look at the risk benefit of any treatment.
Yep.
Yeah. Professor Kiesel, there's another question for you. I think Zinette asked that you showed the relative risk of breast cancer is high in women with endometriosis. So if we treat with progesterone, will it further increase the risk?
Well, that's a question which is often asked because we think that mainly the progestins are the problem, but there is a very, very small statistical change in endometriosis women. We all have to understand that endometriosis-associated cancer is not something which has been done prospectively, etc., etc. So these data are really not so reliable to make these challenging questions and these conclusions. So I personally go with the EMA's recommendation to use estrogen plus progestin. And of course, in general, one would have to say, not just in endometriosis patients, if you use progestins, is that something good? But if you use natural progesterone, maybe risks are smaller.
Yeah,
That's
I'm not. Yeah, I'm not quite sure. We got a question whether that you did mention that progesterone or progestin can be used to treat the endometriosis symptoms for the menopausal women. So in this group, would it increase the risk of breast cancer?
Well, progestin alone probably would not, but the combination, I think, may have in general terms. That's not just related to endometriosis. So we are entering a whole difficult set of questions. So I think this is something which you can do as soon as you have diagnosed the disease. And often you can use the drug just to see if it would help.
Mr. Chairman, can I ask a question to Ludwig? There's much talk about the use of anti-inflammatory drugs as a therapeutic agent in endometriosis. So my question to you would be, what is your overall opinion about this, the future potential, but also in particularly, would it be more or less favorable to use this in postmenopausal women with endometriosis?
Yeah, very good point. I think we don't have extremely good results with the endocrine treatment, because if we look at the disease, it's actually a progestin-resistant disease, which sounds a bit crazy because we use progestational agents to treat the disease. Mm-hmm. We overcome the resistance probably mainly due to higher doses. But still, we have plenty of women who do not respond. So we need non-endocrine related treatment modalities. And there are some in development. They are not very far yet. And one of those are anti-inflammatory. And this is, first of all, because many inflammatory markers are actually changed in endometriosis. So it would be useful to look at that. And I personally think it will help. And second, it will have maybe beneficial effect on some other diseases, which are also related, which are even more severe diseases, probably. So I personally think there is still some room for improvement in this field. And so I believe that that's where the future drug development should go, rather than looking at the difficult titration of endocrine therapies, because we know that this is not sufficient in many cases.
Yeah. And how about its use in postmenopausal women? Because their endocrine interventions, of course, are not very efficacious. So there's even a greater unmet need. Is that a correct statement?
Yeah, the point is that you're right, because in those women who may have local estrogen production by aromatase, it will actually increase prostaglandin production and locally. So that would be an additional point to use these agents. And but it's always difficult to have such a broad acting agent to put in the market. That's my assumption. So we are not very far yet.
Yeah. Okay, thank you very much. I saw a question by Wendy. I think she mentioned about TSEC. I think I saw Professor Kiesel's slide where you mentioned about possibility of combining a SERM with estrogen to treat the symptoms during menopause. Would a TSEC be one of those that you would consider?
Well, TSEC generally is an interesting point. Unfortunately, in Germany, we don't use that much, so we don't have any broad experience on that side. But it's a very valid question to use it. The point we mentioned about the breast cancer issue, so that would be something potentially helpful. So I think it is good, but I'm not really aware of any study answering anything on that point.
That's right. Professor Fauser, do you have any experience on TSEC?
No, I do not.
Yeah, unfortunately, the drug is not available in many parts of the world
Yeah.
as well at this moment in time.
Yeah.
Okay, there's one question I thought we should answer. Maybe either Professor Fauser or Kiesel can answer. Do you recommend combined HRT in all cases of menopause, even if the disease has been removed as surgery? The Dr. Manju said we usually advise combined HRT for 1 to 2 years, followed by estrogen only HRT, as this will reduce the risk of breast cancer compared to combined HRT.
Yeah, that's probably a good way to it, if I may answer that point. I think there's a broad range how well endometriosis has been dealt with by surgery. So I think it's difficult to judge it, especially since those who prescribe HRT are usually not the ones who done the operation. So that usually is a bit of a problem to know in detail how was the actual finding. But assuming that endometriosis has been removed and you think it has not been a major problem or chronically reappearing, and one could say, well, that is a case where you may not need it. But there are no good studies on that, so it's just a personal recommendation. And limiting the duration of treatment, well, that's basically what's done in Germany. So you actually prescribe it for a short time, let's say 1 or 2 years, and then you reevaluate it, and usually you recommend not to use it. So the problem is to take those women who have been premature menopause because they need it for their general health. But in other terms, maybe long-term HRT is not recommended in general. So that's a general question, and it applies to endometriosis patients as well. So maybe if there's some limited time, at one time, I would like to ask Bart Fauser a question about the use of oral contraceptive as a recommendation in young women who are actually not suffering from problems per se, but has been diagnosed PCOS. And many doctors say, well, you need to take it so that it doesn't progress. And this comes back to your initial point of not knowing the natural course. So what do you think about it?
Yeah. Excellent question and relevant in this context. I think it would depend on how you define young. I like the idea from our perspective, it may be even different, but I mean, in general terms, I was very impressed by the early days work of the Semyen group, decades ago, where they showed that after the first years after menarche, a PCOS-like state is physiology. So in young adolescent, oligomenorrhea and having more follicles in your ovaries is a normal state. It's only that in the majority of women, at the late teenage years, there is a recovery to normal, and in some it's not. But we don't know how to define those some. So here again, indeed, it is a question of, do we really understand what the natural cause of disease is at a young age? And what you were saying, in my environment, it's the same, that many, and predominantly by the irregular menstrual cycles, which of course young women usually don't like. So it's just, primarily for the symptoms that they say, okay, if you go on the pill, that problem is over, and it may be good for the disease as well. But if you ask me, what is the evidence that the disease condition is ameliorated with oral contraceptive use, that evidence is not available.
Yeah.
Okay, thank you. There's a question in Spanish. Thanks, David, for translating this. It says, in a patient with endometriosis and heavy menstrual bleeding, can an IUD be combined with gestro, and Diogenes, or is it convenient just to use the IUD alone?
Yeah, the answer is yes. In some patients, even general HRT is actually used by placing hormonal IUDs plus systemic estradiol. So there's actually good evidence that this is helpful and useful if required.
Thank you. Let's just see what else. Okay, there's one more question that says, could you tell us which type of estrogen and progesterone therapy that is suitable for surgical menopause women due to endometriosis? Do you have any preference, Professor Kiesel?
Oh, I think I actually missed a bit the point. Which question was this one?
Could you tell us which type of estrogen and progesterone therapy that is suitable for surgical menopause women due to endometriosis?
Yeah. Sorry. Well, HRT, if we look at the bottom line of the studies, is usually recommended as using non-oral preparations of estrogens, mainly estradiol, plus natural progesterone. Now, there is a little controversy about the use of progesterone to prevent endometrial cancer long-term, because progesterone is not a very potent progestin, but it's a safe progestin. So that's why it's generally recommended in general, not just for endometriosis patients. And I think personally that's okay. It's an unsolved question whether this is true that synthetic progestins would be better to use to prevent endometrial cancer. But that's only after 5 years use. So if you look at patients who generally use it only initially, that may not be a problem. So the answer is estradiol in a non-oral preparation, like gels, etc., and progestin, mainly progesterone, and that's safe for the breast and mainly also for the thrombotic disease. So that's something important. So I would think that's a good approach.
Okay, thank you. Professor Fauser, there's a question for you. As PCOS women transition later in life than non-PCOS women, would it be an option to continue the use of COC and its advantages with respect to cycle control and menopausal symptoms?
Control for menopausal symptoms, for sure. It may not be advisable. You may also go for lower doses. That would do the job as well. For cycle control, yes, but we have to realize that, you know, at an older age, one of the factors which now gets more and more attention is, and that's I think robust now and not clearly how it works, but menopause age is about 3 years later in PCOS women. A very intriguing observation, because more follicles mature. So you would have expected that, you know, there may be an accelerated follicle loss, but that's not the case. Age of menopause is delayed. So when you think about cardiovascular risk later in life, we know that age of menopause is a factor in terms of risk and benefit. So there are multiple issues that you should take into consideration here. So there's no clear-cut answer.
Okay, thank you. Yep. So I think in the interest of time, we will take one more question. In PCOS, is there any data looking at their SHBG levels and their risk of cardiovascular disease?
Ooh. A very good question, and I don't know all the data by heart. I think in the general population there is an association between SHBG levels and later life cardiovascular risk, particularly in PCOS, not that I'm aware of. But I have to dig into the literature to make absolutely sure that that's not the case, but not that I'm aware of.
Yeah. Thank you very much. Okay, I would like to thank both Professor Fauser and Professor Kiesel for a very wonderful talk as well as a discussion. I think we really learned quite a lot from this session. So I think we'll put on the slide now. We would like to welcome you to join us in our World Menopause Congress next year. That will be held in Melbourne. Do keep the date free. It will be shown on the screen in a while. Yep. So this is the date that's there, 19th to 22nd of October, and we look forward to seeing all of you in Melbourne. Thank you very much for joining us for this webinar, and have a great day ahead.
Thank you.
Thank you, and bye-bye.
Bye-bye.